Thanks. Yes, Fong sends her regrets that she was unable to attend because she was really looking forward to it. So I'm really happy to be here, and I want to start off with a huge thank you to LFSA, to David, to everyone really in the audience, to the families coming for just such an amazing and wonderful meeting. I think we've all really learned a lot, and we're building new collaborations, and this is going to go down as one of my favorite photos, I think, ever. So thank you for a wonderful event last night, too. Okay, so I'm actually going to step back and I kind of have to redefine things or look at things, and I wanted to just put up these definitions for the families. So when we talk about surveillance, we're really talking about closely watching a patient's condition, but not treating it unless something changes. But it's really used to find early disease. If you have a disease, has it come back? It's often used for patients who have increased risk of a disease, including cancer. So that fits in why we're talking about surveillance and LFS. And it also means that certain exams and tests are done on a regular schedule. It's exactly what we've been talking about. And really, screening to me means kind of the same thing. And we often use those interchangeably, although you can look into, there's slightly different definitions, but they're really relatively interchangeable. And anyone who has questions or wants to learn more, I encourage you to go to this website. It's the NCI website that has a great dictionary and definitions of lots of things that families and patients often have questions about. So our study, Pyle did a great job in explaining kind of how our study works. I just want to put this up in that we're going to be focusing today on looking at the cancer screening component of it. Our study is a longitudinal cohort study that opened in 2011, and this, as we discussed earlier, is our study flow, where actually the majority of the people in our study participate without coming to the NIH Clinical Center, and that's because we're also in an epidemiology group where we're really good at collecting data. We collect biospecimens from the field, and then a subset of patients come to the clinical center at the NIH. The catch, though, is that to be a patient at the NIH, you have to be enrolled on a research protocol. We're a research hospital, and so it has to be focused on research questions. And that's why we design our studies very specifically with considering sample size, statistical power, that sort of thing. And that's really where we met our accrual goal for the Li-fraumeni syndrome screening study. Our protocol, we start at age 3, and that's purely just because of the logistics and the support staff we have at the clinical center. We don't do as much of the really little kids, so we started our screening protocol at age 3. And it's similar to the Toronto protocol, as you can see. We've recently changed our blood work to every year instead of every 4 months, and I think it's really predominantly because of our patient population at this age. We just found that our yield was quite low, and we're in the process of looking at that data now to better quantify it. And so I'm going to talk about the baseline screening. This was a paper that came out last year, and this was our data. So at the time, we had 116 patients, and this is the results of just that very first screen. So this could be anyone who has a germline P53 mutation. They have to have been off cancer therapy for a few months if they had a recent cancer. And we had 116 people. And what this shows is the number of lesions. That means on either whole body MRI, ultrasound, brain MRI, whatever screening modality, that they had something that required an extra look. So whether it was an extra physical exam, an X-ray, an ultrasound, something like that. So you can see that we had, the majority were all benign lesions identified on whole body MRI, but we found 27. And then on brain MRI, we found some cysts. We actually diagnosed one woman with multiple sclerosis, which was asymptomatic at the time. She didn't have symptoms, but she had findings on her brain MRI. And then some cysts and nodule in the breast MRI. When we look and follow these up, so the majority of those were benign lesions, but we did detect some cancers. So we detected on whole body MRI 4 cancers in this 116 people, 2 breast cancers on breast MRI, the brain MRI. We detected 1, and then we had a child where we detected the her astrocytoma on both her whole body MRI and her targeted brain MRI. Our patients come and get all of these tests done in the same day so we could directly compare. So these were our baseline results, and this is just an example to show you this is what a whole body MRI looks like for us. We do them with contrast, and this was a 47-year-old mutation carrier, and we looked, there's this little thing sort of here in her lung, and we followed up with a subsequent CT scan, and we found this nodule, which turned out to be a very, very early stage lung cancer. And as Dr. Karen said earlier, I think we're seeing lung cancer more often in our older LFS patients. So, but this was actually good news because it was fully resected. She did great. You never would have picked this up earlier. So then that prompted us, we presented our data and prompted us to work with the Life Consortium really by, with the prompting of David Thomas and others to say, well, let's look at the baseline results for everyone. So again, the first screen. We ended up in working with the Life Consortium, 13 institutions from 6 countries, which was great because this was really the largest series that we had put together. And what a meta-analysis is basically combining data from multiple different centers and kind of reanalyzing and looking at it in a kind of compilation way. And the analyses were led really and coordinated by Mandy Ballinger, who's at the Garvan in Australia, and Anna Best, who's a statistical postdoc with us in the group. And I like to show this that David Thomas sent this to me and said, this is what a meta-analysis looks like before it gets dressed up. And you can see that he and Mandy had really, had things printed out, they're checking things off, making sure we had all the data together. And it's a large effort. And I love that photo. So then what we ended up with in all of these centers was, this is just whole body MRI I'm talking about now, okay? So we had 578 P53 mutation carriers, 405 had absolutely nothing seen on the whole body MRI, that's great. 225 lesions in 173 people needed some other test, okay, whether it was imaging or predominantly. Of those, there were neoplasms, which just means growths, something that was growing that maybe shouldn't be, not necessarily malignant. 61 lesions in 54 people. Of those, 19 were benign, okay, so nothing to worry about, but we did have 42 cancers in 39 people at the very first time they analyzed. So then what we do in a meta-analysis is look across the studies, and statistically you give each study a certain weight based on the number of people that they're contributing. So a study that's contributing 50 cases is going to have more weight in the analysis than a study that's contributing 7 cases. Because it gets to be proportionate. So what this shows is when we quantify the number of lesions, so something that on whole body MRI needed something else to look at it, 31% of people at their very first screen had something that needed follow-up. And of those, across all of the studies, the average was about 7% patients had a new cancer at their baseline MRI. Okay. And this really, I think, helped to show the importance of whole body MRI in cancer screening for LFS. So we did have a high false positive rate, so about 43%, which is quite high. But the good news is that all of the screen detective cancers were able to be treated with curative intent. That means that we found them early enough to try to do something about it with cure in mind. But we don't have in the whole compilation of patients yet is the long-term outcomes. Again, this is just a look at that very first scan. So now I'm going to update you on our cancer screening cohort, which we've closed to accrual because we reached the number of individuals we needed for the analysis. To date, we have 134 patients now that we've screened. And as you see here, our number of 4th, 5th, and 6th visits is growing. And the median age is 36 years, and we do have about twice as many women as men in the study, which is actually fairly typical of research studies, and also I think driven by the fact that women with LFS have such a high rate of breast cancer. So at our follow-up visit, so this is visit number 2, we haven't published this data yet, so their second visit, if I go back to that 119 where we have a second visit on, we do have some new cancers that we're picking up at screening. one including a colon that was diagnosed by blood test because the person was slowly becoming anemic. So we were following for anemia. But then we also had a mesothelioma, extremely rare cancer of the lining of the lung, another lung cancer, an ovarian cancer. And when we look at the third visit, we've had about 100 patients we've screened 3 times. We have, again, some more screen-detected cancers, including some breast cancer on breast MRI, another colon cancer, but it was an advanced stage diagnosed in the whole body, more lung and sarcoma, and some other rare cancers, including this carcinoid. So in our current status, as I said, we have more, but what I want to point out is, and this is something that I think for researchers in the field, we really need to think hard about, is interval cancers. So interval cancers mean that you have your test, you had your test a year ago, you're due for your test now, but you had something happen in between your scans. So we've had 2 osteosarcomas, some breast cancers that have come up in interval screening, a stomach cancer, an AML, and then an incidental finding in a woman who was undergoing surgery who had a tubal cancer. And so we need to think about that in the research setting. And then at the false positives, this is something I was really hoping, and it's interesting to see everyone else's data because we still have a high false positive rate. And I think it may be technical, it may be institutional, kind of how the radiologist is reading things. So at our baseline, our false positive rate, meaning we had a lesion that needed something and it turned out to be nothing, was 32%. At our second and third screening, you can see that we haven't really changed that much. We do have a couple of people who are still in follow-up, and so we're not sure if they're going to be false positives or not yet. And so we're still at around a 30% false positive rate in our study on the whole body MRI. So I'll just summarize where this is at, is that we're not sure if the false positive rate is going to decrease, and I think that is where the radiologists are really going to help us in figuring this out. I thought it would, because everyone has anatomic differences. We all have kind of our own special anatomy, and once you kind of define that, you would expect that you would know this looked like this last year, so it's going to look like that this year. And our cancer detection, though, I didn't show the numbers in the flow charts, but we're still finding around 5 to 7% of the patients who are coming through our study have a cancer diagnosed at their screening visit, at their second or third visit. I do also want to point out that at the early stages of our study, we had 3 false positive whole body MRIs. One was, including some that sometimes it's hard to visualize the extremities on the whole body MRI. It depends on the patient. We had a person who had an osteosarcoma of the arm that we just sort of missed it because there was artifact in that area on the whole body MRI. So we've implemented some changes with our radiologists who have been really keen on advancing this. So we're now, before we have a clinical report go to a patient, we're requiring that 2 independent radiologists read it, and we talk with them, and they have to kind of agree before we go back to the patient, because there are lots of little things you can see. We're having at least a monthly, if not more often, meeting where the LFS clinical study team and the radiologists get together and they review all of the cases. And then we also are focused on our clinical outcomes and follow up closely with the patients. We've added some MRI sequences. We're also looking and comparing diffusion-weighted MRI and comparing that results, because we've been using contrast. I would like to get away from that, but we haven't felt, our radiologists haven't quite felt that we were ready, so they're comparing that data now, and I'm really hopeful that we can change that. And the other thing is thinking about sometimes radiology is subjective too, and we think that if a radiologist knows, and this may be part of our study as well, so they know these are patients at high risk of cancer, they're used to reading these screens, and so they're looking for every little teeny tiny thing, and they're being very conservative, which I think is appropriate, but that could also contribute to our false positive rate. So having some sort of systematic approach to all of that could be helpful, I think, for everyone, especially in the community at non-research centers. So my take-home messages for the families is so surveillance can be important because it can identify cancers prior to symptoms, which we've talked about a lot this morning. And I think one of our long research questions, though, is how beneficial is that? And I think Dr. Villani really did a nice job of showing how even if you're still developing the cancer, getting it at a point where you don't have to treat as intensively has got to be a good thing long term. Scans might identify lumps and bumps, and you might need additional testing. And we always say, try not to worry about it, but I know it's impossible not to worry about it. And most of those lumps and bumps are going to be normal variants, right? We all have them. If you put any of us in the scanner, we're all going to have something there. But the other thing to be aware of is that we do have some cancers that are happening between annual exams. And as we've said, I think we're all really good with our kids. We're so vigilant, we're taking good care of them. But if especially for the adults, is that don't delay medical care for new persistent symptoms. So new pain, new fatigue that doesn't fit with what is going on. Just go get it checked out in between. Don't say, oh, my scan is in 3 months, I'll just wait. Go early, okay? And as I said, we're working very hard as a group internationally to bring all this data together to really have statistical power to better understand and better guide this therapy and screening. And with that, I'll end and say thank you. This is really, truly a team effort. We haven't won the Stanley Cup, but we've certainly done a lot of other really important things as a very large group. And I'll thank Feng Mai, who was really instrumental in getting our study up and going, who's now running the cancer genetics program at McGee Women's Hospital in Pittsburgh, and Payal Kincha, who has very nicely stepped up to the principal investigator and clinical lead of our study. And if we have time, I'd be happy to take some questions.
To Central?
So I know one was rib. So one was a rib picked up on a whole body. One was a humerus, and jaw picked up on whole body, right? Yeah. The humerus was distal. I'm pretty sure. Yeah. 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 Okay.
It's okay.
Yep.
Okay, have y'all thought about getting together and putting something together for LFSA as far as treatments, like where I'm from, down in the swamp? We don't have a whole lot, there's really, I'm educated doctors, I'm a doctor, and I have issues that they don't know really what to do with. Like, my iron level is 5 or 3. That's about where it stays, and that's with infusions. I do not go iron. I play the count is sky high, my red blood cell, white blood cells, borderline high, and have been, but they don't know really what
to do. So I didn't know if y'all gotten together to put something maybe together that says, okay, if this, maybe check this, or if this, maybe, because.
So there are some things out there. So first of all, the LFSA website has all of us on it, and the medical advisory board, and I think all of us are happy to help patients navigate the system and help their providers as well. And then there have been several efforts in putting together cancer screening guidelines from the LFS patients, from the pediatric side, and as well as in the adult side.
So we'll have one more question and then we should move on. Thanks. Okay.
Mine is more a comment. As a patient, I personally look at the 43% false negative and think that that's really fine with me. I'd much rather have a false negative and they're catching something.
A false positive.
monitoring-
False positive,
Sorry,
yeah.
excuse me, I have a false positive on my paper. Than not catching it at all. So we're just continuously monitoring. So,
Yeah.
you know, that's wonderful. And then the double radiology comparison is incredible. I think that that needs to be implemented in every hospital because that to me is so important.
Yeah.
Things missed for 4 years, you know, just because they weren't written down, you know, by anybody. But so thank you for saying those things. I really
thank you.
appreciate it.